number 101. Maybe we finish this earlier because there are not that many. We did the bulk of the work yesterday. So I'll read the questions and probably the choices. And you help me eliminate. So question 101, true about celiac sprues except increased number of intraepithelial lymphocytes in the jejunum, loss of microvillus brush border noted, biopsy demonstrated diffuse enteritis, 20% of patients express DQW2 histocompatibility antigen on chromosome 6. So what do we think could be the most appropriate response for this question? Which one is false about celiac sprues? And maybe while you're at that, maybe someone can tell us what celiac sprues is. Let's put our responses in the chat box and let's try and make this a lively session so that we get even more. So someone tells us D, 20% of patients express DQW2 histocompatibility antigen on chromosome 6. So why is this choice wrong? Yeah, because for celiac sprues, you have almost all patients expressing this gene mutation. So yes, the percentage is actually much higher. So almost all the patients. Now, someone has already told us that celiac sprues is also called celiac disease, and it's an immune reaction to gluten. And so what happens is, due to this immune reaction, you have inflammation, and this inflammation will sort of erode the microvilli, therefore making the intestines not absorb the nutrients properly. Therefore, you end up with things like malabsorption, malnutrition, and all that. So basically, the small intestine has become eroded due to immune reactions. So yeah, that's why D was wrong. Because much higher percentage of individuals express this DQW2 histocompatibility antigen on their chromosome number 6. Okay, let's move to the next one. Any questions on that? Let's move to the next. Maybe Nate can mark the answers as we move. So albumin, 69 albumin is the major plasma protein consisting of 60% of the total plasma proteins. Which of the following is not a function of albumin? Transport of iron, nutrient to endothelial cell in the blood vessels. So someone has already told us the work of albumin is not transport iron. What is the work of, which transports iron? What is used to transport iron? Awesome, transferring. You guys are spot on. So you can see in the chat, someone has told me to explain the serology of, sorry, maybe we can move up. Someone has told me to explain the serology of celiac sprues, which I'm not 100% on. So maybe someone can put it in the chat. What will the serology of a person with celiac sprues kind of look like?
Sorry to intervene, but for the serology and the histology, they're very high-end topics. And for the serology, there are actually 3 that you must know. So the first one is IgA anti-tissue transglutaminase. So that's the first one. The second one is anti-endomysial. And the third one is anti-diamidated glial peptide antibodies. I'll write them on the chart. Those are very high-yield topics. They'll be positive in a patient with celiac sprue. And for the histology, you might be brought for the section of the celiac sprue. And to describe it, we know that there is villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis. So those are 3 things that are very, very high-yield.
Awesome, Nate. I think we should pay attention to those and maybe need to put them in the chat so that we can have them. So crypt hyperplasia and villus atrophy. That's some of and also now the diffuse enteritis, some of the histologic features. Now I will go to question 1 or 2. Which one of the listed substances is secreted by malignant plasma cells in individuals with multiple myeloma and is an osteoclastic activator factor that produces the characteristic lytic bone lesions? Is it platelet-derived growth factor? Is it interleukin-1, transforming growth factor beta, tumor necrosis factor, or interleukin-6? Someone says interleukin-6. Can you get a variety of responses? Any other different choice or answer? Someone says B, interleukin-1. Interleukin-1. Yeah, so I think I will agree with one saying interleukin-1. So what is multiple myeloma? So basically multiple myeloma is where you have malignant plasma cells, right? So when you have this malignant plasma cells, basically there is neoplastic proliferation of these plasma cells. So the malignant plasma cells might infiltrate the bone marrow, and then they might lead to defective hematopoiesis or suppressed hematopoiesis. And then you get symptoms like leukopenia, like thrombocytopenia and anemia. Also, these malignant cells may proliferate due to pro-osteogenic factors such as tumor necrosis factor alpha, interleukin-1, and rank L, which lead to osteoclastic bone lesions, which now occur as a result of these pro-osteogenic factors. So if I might add or just reiterate, the osteogenic growth factors or the pro-osteogenic growth factors are tumor necrosis factor alpha, interleukin-1, and rank L. So the reason why we did not go with platelet growth factor is because it is secreted by platelet cells, also the platelets and macrophages, and this one induces vascular remodeling and smooth muscle cell migration and stimulates fibrous growth and collagen synthesis. So it's kind of counterintuitive to include it here. So the best choice was interleukin-1. Any questions on that? We'll move to the next one. So I said the pro-osteoclastic growth factor, the pro-osteogenic factors are interleukin-1, tumor necrosis factor alpha, and rank L. RAKL. We'll move to the next question. AIDS defining malignancies except choices are primary effusion lymphoma, Kaposi sarcoma, squamous cell carcinoma of the anus, squamous cell carcinoma of the cervix, squamous cell carcinoma of the skin. Do you think all the following are AIDS defining malignancies except? Yes, so someone tells us E, a lot of responses say E, and I agree with those. Squamous cell carcinoma of the skin. So the squamous cell carcinoma of the skin, which type? Is it defining or associated? Oh, I'm being told this is even a hematology question, sorry. So I might have done that. Maybe we can just answer it. Is squamous cell carcinoma of the skin an AIDS defining or an AIDS associated? Yes, it's AIDS associated. Let's move to the next one. So 105 is clinical chemistry. So the next one is 106. Acute liver failure is defined as is associated with viral infections occurring within 2 weeks of assault, is associated with disseminated malignancy, occurs within 6 months, occurs in underlying liver disease. What would be the most appropriate response? What is acute liver failure? Yeah, so the responses are D, occurring within 6 months, and I agree with that. The answer is not A, because I'm associated with viral infections. This is basically just the definition of hepatitis, mostly. Now, because these viral insults are mostly hepatitis A, B, and the rest. occurring within 2 weeks of assault. This is what is known as fulminant liver failure, associated with disseminated malignancy. So basically, this might be maybe hepatocellular carcinomatosis or something to that tune. Occurs in underlying chronic disease, so underlying liver disease. So this is probably just chronic. So the best response would have been occurring within 6 months. Next one, 107 is hematology. We'll skip it. 108 is clinical chemistry. We'll skip that as well. 100, we'll do 109. Now, which of the following is not a histological subtype of adenocarcinoma? Acinar carcinoma, papillary, large cell carcinoma, mucinous carcinoma, and lipidic carcinoma. So which one is the most appropriate response? I see answer streaming, and it's large cell carcinoma. So if large cell carcinoma is not a subtype of lung adenocarcinoma, what is it? Under which category of lung carcinoma is it? Yes, so it is a non-small cell carcinoma. Good. Non-small cell lung cancer. Yeah. So maybe we can mention the other non-small cell cancers. Lung cancer. Maybe we can mention, let's put our responses in the chat, other than small cell lung cancer. Yes, squamous cell carcinoma. Any other? Neuroendocrine and carcinoid. So for carcinoid tumors, I'm not 100% sure that they are part of the small cell, but and also the carcinoid tumors, the bronchiogenic carcinoids are neuroendocrine in origin. And also last time we said that the small cell carcinomas, small cell, are also neuroendocrine. But you say the difference is the small cell arise from the neuroendocrine cells of Wilczynski, but the carcinoid bronchial originate from other neuroendocrine tissues. So maybe I see Nate says that he sent explanation to the serology of gluten-losing enteropathy in the WhatsApp group chat. Maybe you can where were we? So we said the one which is not a histologic subtype of adenocarcinoma is large cell. That is a subtype of small cell carcinoma, lung carcinomas. Let's move to the next question. That is 110. The least rate of recurrence of native kidney disease in renal allografts are observed in IgA nephropathy, PLAR2-related membranous glomerulonephritis, anti-GBM neuropathy, Alport syndrome, hepatitis C virus related to cytoglobinemia. So what would be the most appropriate response for this question? Which one shows the least rate of recurrence? Yeah, so the least rate of recurrence is IgA neuropathy. This is under glomerular diseases, and you have basically, this is the histopathology of the kidney, the topic where this is. So histopathology of native pathology in the kidney, and you look at the classification based on recurrent native pathology classification. Now, the highest will be PLAR2A, which is also known as membranous nephropathy. And then the least is IgA nephropathy. So maybe I can just run you quickly on the three which I picked and I thought they were major in this choice, which will be confusing. So maybe we can start by defining what is IgA nephropathy, what are some of its causes, and is it a nephrotic or a nephritic syndrome? So IgA nephropathy is a nephritic syndrome. So nephritic, basically, instead of presenting with proteinuria, it's presented with hematuria, right? Now, the primary cause could be things like SLE, things like post-infectious glomerulonephritis. Those are the primary causes. Also, you have some secondary causes such as liver disease, such as cirrhosis, viral hepatitis, and you also have GIT diseases such as Crohn's and ulcerative colitis, and not to mention like celiac. These are secondary causes of IgA nephropathy. Now, maybe we can now describe how these above diseases, the primary ones and the secondary ones, can lead to IgA nephropathy. So we look at IgA nephropathy's mechanism of action. So from the word IgA nephropathy, it means that IgA has a role to play in the nephron pathology. So IgA is playing a role in pathology of the nephrons. So how does IgA play a role in pathology in the nephrons? So usually you'll have abnormal IgAs in the body from whatever the cause. Maybe SLE is causing production of abnormal IgAs. Maybe liver disease is causing production of abnormal IgAs. So because you have these abnormal IgAs, the immune complex, the body will recognize this as an antigen or a foreign material. So it will mount an immune response towards it, and then an immune complex will be formed. And then these antibodies that will be generated towards this abnormal IgA will probably or will mostly be IgGs. So these IgGs are generated and form an immune complex with the abnormal IgAs. Now, the immune complex goes through the blood and then it's trapped in the kidneys, specifically in the mesangium. So the mesangium is the connective tissue of the kidneys. Now, in the mesangium, you have this IgA complex being bound to alternative complement pathway. Then this will lead to the release of pro-inflammatory cytokines. When the pro-inflammatory cytokines are released, they'll sort of signal macrophages to come into this site of inflammation, and then they'll cause further inflammation. This inflammation will lead to glomerular injury, and that's sort of the mechanism of action of IgA nephropathy. That's how it comes about. So when you hear this, not a perplexing term, just remember IgA is causing a neuronal nephronal pathology. And this nephropathology is because the IgA is a mutant form, and it can be caused by diseases which are primary or secondary. Now, for PLAR2, we've said also it's called membranous membranous, I think, glomerulonephritis, right? Is mainly due to, it's mainly primary, but can be caused by some secondary causes, such as rheumatoid arthritis and sarcoidosis and Hashimoto's and things like Graves' disease. It can also be caused by drugs such as NSAIDs and penicillamines. Also, it can be caused by infections such as hepatitis B, hepatitis C, and it can be caused also by carcinomas such as solid tumors, and also other causes such as sickle cell disease. Now, what is the mechanism of action of membranous neuropathy? So here you have damages caused by subendothelial immune deposits that build up between the podocytes and the glomerular basement membrane. So I think this is what you call subendothelial. Now, once you have this, they activate the complement system, causing damage to the podocytes and the mesangium. So for this, in the mesangial matrix, you not notice any hypercellularity or inflammation. There will just be damage. Now, the last one I picked on was Alport syndrome. And maybe I forgot to mention this membranous nephropathy is a nephrotic syndrome. So there will be production of proteins in urine. Now for Alport syndrome, it's a nephritic syndrome. Now for Alports, you have a mutation in the gene coding for type 4 collagen. And with that type 4 collagen, which is used in the building of the glomerular basement membrane, you will have a very thin glomerular basement membrane, which is prone to splits. And these splits will allow substances to pass through in and out uncontrollably. And this usually occurs, or you can notice, or you can diagnose Alports. For example, when you notice that there's Alport syndrome can cause early hearing loss in late childhood or in adolescence. Now, I think that's the major thing about Alport. So it's basically mutation in the gene coding for type 4 collagen. That's the most important one to grasp. And also it is a nephritic syndrome. Okay. I hope that is well understood. Any questions on that? Awesome, guys. So maybe we'll move to next question. I think this is immuno, so we'll skip it. And so also 112 is immuno, skip it. 113 is hematology. 114 is there, we'll do 114. Two about laryngeal carcinomas except manifest with hoarseness of voice, often related to tobacco smoke, usually develops directly on the vocal cords. Alcohol is a risk factor. Most of them are adenocarcinomas. So the following are true. Which one is false? I see multiple responses and the answer is E, and I also agree. So most of the laryngeal carcinomas are not adenocarcinomas. What cells are they formed of mostly? What is their histology? What is the histologically dominant cell in laryngeal carcinomas? Exactly, squamous cell carcinomas. That's why choice E was correct. Excellent, guys. See you following, and I think we are doing well. Now, 115 is clinical chemistry. Maybe we do 116. Common skin lesions diagnosable through exfoliative cytology except tinea, cutaneous tuberculosis, tinea capitis, squamous cell carcinoma, rhabdomyosarcoma, leishmaniasis. Now, what do you think could be the most appropriate response? Yeah, someone says D. Why do we suspect D will be the most appropriate response here? Yeah, because it mostly affects rhabdomyosarcoma is a malignancy of skeletal muscle. So maybe instead of exfoliative cytology, you can use other things like biopsies or muscle biopsies. So that's why D was wrong. Next, any questions so far? Okay. Next is 117, which is clinical chemistry. So maybe we'll do 118. Gastrointestinal stromal tumors are commonest in. Let's put the responses. Someone says D, and I agree with them. So the prevalences are as follows. So the colon consists of 10 to 15%, the duodenum 25 to 30, the stomach 50 to 55 to 60. So it takes a huge proportion of these stromal tumors of the gastrointestinal tract. So the correct choice will be stomach. Okay, go to the next one. I think that's clinical chemistry. Mistaken. Then 126 is hematology. 127 is hematology as well. 128 is clinical chemistry. 123 is hematology. 124 is hematology. So maybe we can do 125. Yeah. Not an important therapeutic biomarker of intestinal type gastric adenocarcinoma. So which one of these choices is not an important therapeutic biomarker for gastric adenocarcinomas? Maybe let's put our responses in the chat box. Someone says C. Why did you go for C? So maybe we say C because we know HER2 is used or is found in is a biomarker for breast cancer. However, also HER2 is also found in gastric type of adenocarcinoma. It's also raised there. Now the correct response will be D. ALK ROS1 fusion. So basically, this is found in lung cancers. Also, to note, the lack of ROS1 gene rearrangement is present in glioblastoma multiforme. So it can be found mutations in this ROS1 gene can lead to glioblastoma multiforme. And when this ROS1 fuses with ALK, they'll form lung cancers. And it does not play a role, major role in gastric adenocarcinomatosis. So the correct response would be D. Okay, we move to the next question. True of Brody abscesses. For this, I was not able to fully explain this, so maybe Nate could assist us here. Or any other person in the chat box who feels like they can explain or sort of does this better. Anyone?
Okay, I can try.
Mm-hmm.
So the question is, what is a Brody abscess? So we were taught this when we were doing osteomyelitis. Yes, so I can start by eliminating choice D. So choice D is wrong. Choice D is wrong. Osteomyelitis, you know, the common cause of osteomyelitis is a bacteria, so Staph aureus. Choice, I can also eliminate choice A. Visualized on cortical defect on X-ray. No, it's not. Choice E often leads to septicemia. No, it is a very local infection, does not spread. So choice B is actually the predominantly has lymphoplasmic infiltrate. This is actually true. This one.
Yeah, thank you, dude, for that. He's helped us come to the answer by elimination. So that was good work. You go to the next question, 127. Physical examination that finds multiple palpable pruritic lesions on the legs of a 7-year-old boy is most suggestive of. Let's put our responses in the chat box. So could it be hemorrhage secondary to hypersensitivity vasculitis, bleeding secondary to excessive corticosteroids, erythema secondary to active hyperemia, telangiectasis secondary to okay, someone has already come up with the answer. You've told us the answer is hemorrhage secondary to hypersensitivity vasculitis, and I agree. Maybe we can try eliminate. Now, for bleeding secondary to excessive corticosteroids, while excess corticosteroid use might lead to skin thinning and easy bruising, palpable pruritic lesions are more indicative of vasculitis. That's why that is wrong. And now for C, erythema. What is erythema? So erythema basically refers to redness of the skin due to increased blood flow in that particular area of the skin. This is not typically associated with palpable pruritic lesions. Now, for telangiectasis, sorry, I just butcher that all the time, refers to dilated superficial blood vessels. While this might lead to visible blood vessels, it does not usually cause palpable pruritic lesions. Now, for thrombosis secondary to viral infection, thrombosis is basically formation of blood clots, which will not lead to palpable pruritic lesions. So the best response will have been A. So hemorrhage secondary to hypersensitivity vasculitis. Next question. The commonest disease affecting the gastric mucosa is it food-related gastritis, fungal gastritis, fungal neoplastic lesions, bacterial gastritis, viral gastritis? Let's put our responses in the chat. If someone says bacterial gastritis, and I agree with them. So bacterial gastritis is the first, the commonest cause of gastric mucosa, disease of the gastric mucosa, and then maybe I would argue food-related gastritis, but the primary one is bacterial gastritis. And which is this common bacteria that causes this bacterial gastritis? H. pylori, correct. You guys are doing well. Thank you. I see you following. The next question, 129. This is intrinsic causes of acute kidney injury include the following: paracetamol poisoning, hepatorenal syndrome, acute pancreatitis. I think this is clinical chemistry. Yeah, I think that's clinical chemistry, so I'll leave that to whoever is supposed to do that. We move to the next question, below the one below. The least common histologic finding in fibrocystic disease of the breast: epithelial ductal hyperplasia, bilateral multifocal changes, apocrine metaplasia, stromal fibrosis, follicular invasive lobular carcinoma. So yes, I agree with your responses. E, focal invasive lobar carcinoma. So usually when you have this, the risk of cancer is usually not increased. So this fibrocystic disease is most common in premenstrual women, specifically those between the ages of 20 to 50 years. You have two subtypes. Maybe you can classify it into two subtypes. So you have the non-proliferative lesions, which include simple cysts, which are fluid-filled, and you have ductal dilation, and what you call the blue dome. Then you have the papillary apocrine change or metaplasia and stromal fibrosis. These are the non-proliferative lesions. Then you have the proliferative lesions, which include sclerosing adenosis and epithelial hyperplasia. So that's kind of the two kind of lesions you can get with cystic disease of the breast. And you have those are explained basically the choices. So I've been asked to repeat. Now we have non-proliferative lesions, which include simple cysts, which are fluid-filled,